talking about a healing-centric, trauma-informed approach to how we can shore up the foundation of our own self-care, nurse self-care, and importantly, our students' self-care. And Cipriano, and you see there in the image that it was a truth arrow to my healer's heart when she asked for help, because nurses do not feel valued or supported, which we all know that. And that we need to grow our workforce supply and retain that workforce. And then to me, my healer's heart heard that as, Lorre, please do your part to mitigate and ameliorate nurse traumatization. And so that shifted the arc of my scholarship, and I gave that a lot of thought, and I really came to the conclusion that it's not enough just to grow and retain an international workforce. We need to end nurse traumatization so we can ensure a healthy, thriving workforce. And to do that, we have to start learning how to facilitate nervous system regulation and trauma healing at the individual and collective levels. So I shoved the first book under my mattress in my room, and I grabbed my computer and I got to work. And so there's the book that will be coming out later this year. And it's really how I'm answering the call. This book is written for a general professional audience. It's not a textbook, and it's intended to meet nurses in their living spaces with me as their trusted mentor and friend over a cup of tea, guiding them through the healing that may be before them. So that is me. And let's hear about what you're seeing in your students and in your classroom. So if you can do, we're going to do just a super low tech. We'll just have you respond in the chat with A, B, C, or D. To what degree are you encountering student resilience challenges? And Karen, I'll keep an eye on if you can help me too. Anybody want to throw, are you seeing, here comes some responses. A lot more than usual. Yeah, more than usual, a lot more. Oh my God, too much. I hear that. And about the usual amount for some. So we're kind of all over the spectrum, but I saw mostly B's and C's. And in our program, I teach in the BSNIH, we're seeing quite an uptick of student resilience challenges. So let me ask our second getting to know you question. How familiar are you with polyvagal theory? And that'll just help me with the pacing of this presentation. A, B, C, or D, wherever, you know, if you've never heard of it, that's fine too. If it's your life, I'm here for that too. Okay, so a lot of people, it sounds familiar, somewhat familiar, very familiar. All right, so we seem to be clustered pretty much around B, if I had to pick the midpoint. So that's great. Well, and so we're in good shape because for me, it's D. This has become my life over the last few years. And so let me just ask this third and final getting to know you question. What is your comfort level supporting students in navigating their nervous systems as a self-caring foundation? So student nervous system, self-care, comfort or with that, or openness. So I'm seeing a lot of B's already on it. Wonderful. So we're kind of across the spectrum, which would be expected because this is a really new area, relatively new area of using education science. So today that we're going to talk about all that and more. We're going to talk about trauma-informed nursing education, the middle range theory that supports that, signs. You'll learn how to recognize the signs of students who are being challenged in their nervous system regulation, and some healing-centric strategies. So with that in mind, let's start with nursing education, because that's where we are at as educators. So the AACN, as it turns out, has a pretty strong position statement is assume everyone has experienced some type of trauma in their lives. And no, as educators, we don't have to know everybody's history. In fact, it may be detrimental to even ask them to unpack that. That's not relevant to what we can do as educators. And the goal isn't to uncover the trauma, but rather to recognize it. So we're going to explore that. throughout this presentation. In nurse education today, Goddard et al. Said the need for trauma-informed education in nursing is critical, and I echo that. That the student-educator connection is an essential part of being human and a foundation for regulation, key word there, that you'll learn more about coming up during nursing school. Goddard et al. Goes on to say that we can use SAMHSA's framework and apply the 4 R's as underlying assumptions for how we can really affect trauma-informed, healing-centric nursing education. So the first 3 you see I have check mark there because we're going to talk about those in this presentation. Realizing that trauma has widespread impacts and many pathways to healing. Recognizing the signs and symptoms in our students along with those in our care. And then also how to respond by integrating this knowledge into trauma-informed system-wide practices and procedures. And if we do the first 3, then the last one occurs on itself, which is resisting traumatization in others. So that's the literature. Now let's talk about the middle range theory in which my work is grounded and hopefully yours. And this was another one of those OMG healer's heart got hit by another truth arrow. As while I was cobbling this together, I was off in different disciplines. We didn't have, this theory wasn't out yet. And so I was over in relational neuroscience, polyvagal theory, transpersonal neurobiology, and I was cobbling together the philosophical and conceptual framework to put forth, which is within my skill set, but it was a stretch and it was really hard. I was grinding, I was doing it, but this is a passion project, weekends and evenings. Some of them were very long as I labored. And then this showed up in my inbox because I'm on 10,000 listservs, right? Like you probably are. And I put the gift wrapping up there because I was sure it was a gift just for me, even though it wasn't. But Dr. Haelan Foley of Purdue University put forth her middle range theory of nurse psychological trauma and did a far better job than what I could have done. And I'm just so immensely grateful for her work because it is really, it's timely, it's relevant, it's urgent. And it got me back into writing the book I was writing as opposed to being out in the weeds, deriving a conceptual framework. So I'm just so grateful to Dr. Foley. And her framework goes something, her model goes like this. In a lifetime, we all experience what are known as avoidable and unavoidable traumas. And if you look to the left half, as individuals, nurses, we're individuals first. And we can experience all of these in our lifetime. And so an acute trauma might be something like a car accident. A chronic trauma, a chapter from my lived history is 20 years I was living in a house with toxic mold to the point where I couldn't get out of bed and couldn't walk. And so obviously I've recovered, but that would be an example of chronic trauma. I'm no longer living in the house, in case anybody's wondering. That was so a long time ago. Complex trauma is a situation where we have both acute and chronic and any of the other types of trauma that are manifesting together or over a prolonged period of time. There's developmental trauma, which would include ACEs, which are the adverse childhood events, and attachment traumas, which are profoundly impactful in all the wrong kind of ways, and then neglect and abuse. So as nurses, we're humans first. And this is part of the tapestry of our lived experience that can inform or at least comes with us into our practice each day. And then in practice, wherever we are in our nursing practice, we are exposed to vicarious or secondary trauma that's inherent with the profession of nursing. There's a lot of historical trauma associated with nursing. If you look at it through a sociological lens, as many have done, it's a profession and or occupation, depending on who you read, that has a lot of systemic oppression, marginalization, and disenfranchisement, which is a topic for another day. But it's really challenging, the historical trauma that nurses face. We are exposed to all sorts of workplace violences from our patients and also from one another through incivilities and other forms of lateral violence. There's system-induced trauma, and this is what we're experiencing and have been experiencing for some time, aggravated by the pandemic, but certainly not, not the root cause, is that, especially here in the US, our healthcare system is starting to implode. Once again, we are the most expensive system with the poorest outcomes of developed countries. And so this is resulting in all sorts of traumas. One of which is insufficient resource traumas. And this is what has nurses out in the streets striking and advocating. We don't have enough personnel. We don't have enough equipment. We don't have the resources that we need. And then as a result of that, there's an uptick of adverse events and sentinel events, which results in second victim trauma, which you no doubt have read, as I have, in the headlines of nurses being raked over the coals for avoidable errors that but truly were system induced. And then we have traumas from natural disasters. And then we take this middle range theory, and then the overlay is this prolonged global pandemic. So we have trauma upon trauma upon trauma. Now, it's important to note that not everyone who is exposed to trauma is traumatized, right? So there's a differentiation there. And we're going to look at what happens to a traumatized nursing. So you might have experienced all of these things and be thriving, but other people may have experienced the same thing and then they may be struggling. And so let's take a look at why that might be. Our students similarly come into nursing school and they're surrounded by nurses, their faculty, in their skills lab, in their clinicals, and their precepting nurses who are experienced or have experienced their own unique individual traumas in addition to those nurse-specific traumas. So it can be a lot for a student's nervous system to be in this, what I call the trauma sandwich, which doesn't mean that every student is experiencing this, but many are. And that's probably why we're seeing the uptick. So this work is grounded in the first two integrative nursing principles. This all has to do with that we are inseparable from our systems and contexts in which we live and work. And also my work, the framework I'm putting forth, leverages on our innate capacity for healing. And so just so you know where I've grounded it in the integrative paradigm. Let's take a breath. That might have been a lot of information to absorb. And we have some more coming. But I just want you to take a moment to let your synapses stop firing. Just take a breath, feel your feet on the floor, feel the back in your chair. And for me, feel a sip of tea to moisten my throat. All right. So let's now take just kind of a refresher. I know some of you are very familiar, some of you are sort of familiar. So let's just kind of go through this together as a refresher. So what is trauma? It's what happens inside of you as a result of what happens to you. So many of us take an outward approach when we think of traumatization. We think of the bad things that have happened, and while important and not to in any way minimize those, where the real disruption and the opportunity for healing is within. What we learned is that unhealed or non-integrated trauma is embodied. In my work, I call those unhealed bits of wisdom, because when conditions are right, they will emerge for healing. So what happens is that trauma is not just limited to the event itself that happened sometimes in the past, but rather it's the imprint that experience left on the mind, body, and brain. And so this is what we really are leaning into in my presentation. And this is my mentor of over 30 years, Dr. Bonnie Badenoch. I just cannot say enough gratitude for her and her what she has brought to this field in transpersonal neurobiology. And a lot of the reasons that the primary reason why our unhealed traumas or the trauma that happens to us in the moment cannot fully integrate is because we don't have who we perceive we need as being with us before, during, or after the event. Now, that's not to say that we didn't have people who loved us and cared for us. We may or may not have had those people, but they themselves may not have been prepared to do the work of healing. They themselves have not, maybe they had their own traumas that they were limited in helping you get through your own. And so this is, of course, how legacies of trauma can be embodied and transmitted across generations. And so we really, when we think about trauma, we have to think about the physiological, we have to think about the relational neuroscience, and we also have to think about the transpersonal neurobiology, which is fascinating. Now, you may have seen this book, or it might have shown up. I've read it. It was fabulous. But what I want to really honor and acknowledge Dr. Perry for his recommendation that we shift the paradigm. We start shifting the paradigm from what's wrong with me, what's wrong with you, what's wrong with us or them, into what happened. What happened to you? And for our students, we don't have to know. We don't need a trauma history, but understanding that something has happened to them, just as many things have happened to us that might be causing a dysregulated response that may be seen as inappropriate and probably is contextually inappropriate, and they need help in navigating that. So we'll talk a little bit in a minute about Dr. Stephen Porges' work on polyvagal theory. The threat detector is a term that he coined that is who is signaling. It's the process. It's not a who, really, but in my second grade renditions, which you'll see shortly, it looks like it's a who, but it's not. And signals to the threat detector, signals to your autonomic nervous system, which you'll hear me say nervous system a lot because I drop the autonomic when I'm presenting because it's just a mouthful. So if you hear me just say nervous system, I mean autonomic nervous system. And that autonomic ANS evolved over 300 to 500 million years, and it responds to the cues sent by the threat detector, who has one job only, and that's to keep you safe. So any unresolved trauma or dysregulation that gets stuck, it gets stored in the body. And then over time, what can happen in many people, and I suggest that the prolonged pandemic has exacerbated this mechanism, is that the threat detector and the autonomic nervous system gets stuck in the on position. So it's like if you have a fire alarm in your master bedroom that's completely across the house from your kitchen, and then you turn on the burner in your kitchen, and then the master bedroom fire alarm is firing 911 decibel warnings. And so what happens is that over time we can have what were once adaptive responses to a similar stressor become maladaptive in the current context. And this is what we're seeing in our students. In fact, I just had a student appointment from 2 to 3, and this is exactly what we worked on. And so for trauma, it's helpful to think of the brain and the autonomic nervous system as pattern recognition systems. So we have, this is Dr. Porges' work again, neuroception, which is this threat detector process that is constant surveillance, taking in all the sensory information, and it triangulates it with the repository, including your non-integrated or your unhealed bits of wisdom. Right. So it's going to triangulate the present stimuli with everything in your past. And it looks something like this. So you can see the little exclamation point over here. This is our threat detector. And this down here is our vagus nerve. And this is the repository of your entire lived experiences, that those traumatic events that have been fully integrated and those that have not, that are still stored in the bodily circuits and neuroplexuses. So there's 3 basic circuits. There's the ventral vagal circuit, which is sort of the I am and we are safe, kind of maybe hopefully how you're all feeling with me here today. I hope you feel very safe and supported and connected. When we encounter a perceived or real threat, then the sympathetic, and we're all very familiar with this, flight or flight, nothing new there. I call that the all hands on deck circuit. And if we get blow past that, or there's extreme danger, then the dorsal vagal tone will come on, and that is no hands on deck. So how that manifests in the organism, and in this case our students, is when they're ventral vagal, they're socially engaged. They can communicate, they can feel, they can see the big picture of whatever you're teaching. They're connected with you and their colleagues. They're calm, cool, collected, and connected, just where we want them to be. But nursing school is stressful. And so a lot of times they're going to move into that sympathetic, and that's okay. And but not too much of a good thing. You'll see that in a minute. So that's where active protection comes in. And that's our flight or fight that we're all familiar with. And so if it's fight, they're moving towards the stimulus. And if it's flight, they're moving away from the stimulus. And then if that is not getting the job done, the threat detector is like, nope, that's not doing it, then that dorsal vagal circuit is going to come online. And that's the passive protection. And that's where your students are starting to feel shut down. Maybe they can't answer a simple question in debrief. They're numb. They might be starting to dissociate a little bit. They might feel hopeless or trapped. And so those are all expected under polyvagal theory. And as with all things in nursing and healthcare, nothing is as simple as 1, 2, 3. Then we have all the hybrids that are derived from how these 3 primary circuits, ventral, sympathetic, and dorsal vagal, come online, and into whether it's play, stillness, fawning, or freeze. And so let me just go to, so you don't have to know this slide. This is just kind of showing you how it works. But I think this is actually a better depiction in terms of, think of these circuits and their hybrids when they come online like dimmer switches. And so each of us right now, if we experienced a traumatic event in this Zoom container, each of us would be experiencing the same event, but each of us, in terms of what circuits and hybrids are coming online, is going to be informed largely by how our nervous system has adapted over time and what non-integrated traumas we embody. So think of these circuits and hybrids like dimmer switches, and you'll see in the far right, in the safety circuit, when we're able to be still, we have for example, our ventral vagal is high, which is wonderful. Our sympathetic is low, which means the stressors in the environment are very manageable. And then that a smidge. I might have, a little bit of dorsal vagal online, and Karen might have just a smidge more. And so this is how we get a lot of variance into how we respond to the threats and stressors, whether they're perceived or real. Now, on the right, you'll see this is how polyvagal, if you've seen it in any of your textbooks, this is almost always the chart that is shown. And we already know a lot of this just by virtue of being nurses. So I'm not going to review that, other than to say that when we go into these hybrids that are somewhat maladaptive in nursing school, these are involuntary subcortical responses. They're not conscious choices. And so our goal as educators, and indeed as nurses and as humans in my worldview, that really our goal is regulation. And so the regulation is this white arrow. Karen, nod your head if my blue cursor is showing up. Okay, thank you. So where we really want to be is this is where regulation is. We're in ventral vagal. Oh, a stressor happens. We go into a little bit of sympathetic. Okay, we resolve it. Okay, we're returning back. And so we want to stay in this sine wave, and that is our nervous system regulation. But you can see there's a whole bunch that is not that. And so if we put it sort of back on this ladder, and it's a hierarchical ladder, which is, I failed to mention earlier, is that you can't just go from ventral vagal down to dorsal vagal. You have to go through the sympathetic circuit and vice versa. So these dimmer switches do have an order to them. And then on the left, you'll see the hybrid. So what happens a lot of times, and this is the student I was just in the meeting with at 2:00. She's like, I'm trying to meditate, and I'm trying to be still, but it's just not working for me. And so, I kind of worked through some of the things that we're learning about today, and we'll come to find out her sympathetic was, her sympathetic tone was pretty strong. What she needed to do was move. She's got adrenaline, norepinephrine, all cortisol, all the players. are activated and she was experiencing this flight or fight, and she really felt like she needed, as we unpacked it, that maybe sitting on a meditation cushion wasn't the right thing for her nervous system at that time, that maybe some movement-based mindfulness. And so we did some exercises together, and sure enough, she really was able to find a better space to be in her nervous system as a result to her stress. So what does this look like in the brain? All right, so you showed me all your second grade drawings that you made on Canva, which took me a million years because I'm not proficient, but I'm learning. So this is Dan Siegel's work, and you may have seen this, the model of the hand. So what happens on the left is when we're regulated, you can see that the thumb is tucked right in there, the thumb being the limbic system, and it's nestled in the cerebral cortex and the prefrontal cortex. And we are going through the day as regulated human beings who are functioning and doing well. And then we get a threat perceived or real, stressor perceived or real, and it's triangulated with what is embodied. And what happens is that the nervous system dysregulates because that's how the nervous system has adapted to prior experiences that we don't know about in our students. We don't have to know about that, but we do need to know that when they're crying for an hour after an exam and are so dysregulated that they can't really compose themselves, we do need to recognize that what's happened is the rational part of their brain, their prefrontal and their cerebral cortex is flipped, and now the limbic system is in the driver's seat, and this is all happening subcortically. So that means that they're not conscious choices. And it's also happening below the levels of cognition and language, which is why we can't think or talk our way out of it at that time. And so, we're trying to reason with them and rationalize with them. And it's, that could almost be a little bit more exacerbating to what they're experiencing internally. And so helping them learn the language of their nervous system. Because this is what it feels like to them. Like they're out of control. This is like, I don't normally behave this way. I don't know why I'm crying. I don't know why I'm stressing. I'm doing these things that I normally don't do. And so reassuring them that this is just an adaptation of your nervous system. That's all it is. And we can retrain that. We really can. You're not stuck. You're not broken. You're adaptive. And you have some learning to do so that you can learn how to regulate. And how do we go about doing that? Is by learning how to speak the embodied language of our nervous system. And we do that through somatic practices, neural exercises, and that leads us to really optimize the properties of neuroplasticity so that we can build new pathways. We can support our nervous system regulation and reshape that tone so that we can be regulated in that window of tolerance. So again, I like the window. This slide for many people is overwhelming because it's a great slide, but it's a lot of information. So what I like to do is I like to make a visual for the people I work in. This is where we want to be, and it's this window over here. You want that window wide open so that you are right in the sweet spot of your nervous system. And so we do that by spending a lot of time in our ventral vagal tone to the best of our ability. You'll notice I keep touching my heart, and that's a strategy that is activating the ventral vagal area through the nervous system tissue that's there. And we want to manage our stressors so that our sympathetic system doesn't get overwhelmed, and we don't want that dorsal vagal to come online because that really closes the window. And the people that I work with describe it as it gets so small it actually just knocks them out of their window of tolerance. So helping our students to be in their window of tolerance is sort of the gig. Holy heck, so how do we do that? Like, what's an educator to do? Well, the first thing is to take care of your nervous system first so that you can co-regulate with your students. So a big takeaway is that dysregulation is an adaptation and not a choice. And that's really going to shift us into a place of compassion and empathy. Not that we aren't already, but if we don't understand what's happening, it's really hard to get perplexed. And in some cases, and it's certainly happened to me, where it's frustrating because everything I'm doing in my educator bag of tricks is not getting me the results that I'm seeking. And so, I, like you've probably been in a lot of meetings this year with people in our own college and other places that, well, maybe the students aren't maybe they're not a good fit for nursing. And that might be true. I mean, not everybody is suited, but also maybe the student just needs some support navigating their nervous system. Because as nurses, we just saw that they're going to be exposed to all kinds of nurse-specific trauma. So how about if we help them with that now and then we can see if they're suited to the profession or not. In other words, let's not let their dysregulated nervous system drive that important decision. Because just as each of us has a unique lived experience in trauma exposure, we all have unique healing roadmaps. And this was the challenge that I gave myself when I opened that email that day, is how with the complexity of all the traumatization that nurses are experiencing, indeed individuals, how can I derive a framework that's going to work for everybody? And this took me like a year. I'm a slow thinker. But what I came up with is your innate care plan. And you can see how this is grounded in integrative nursing, right? Principles 1 and 2. It's very simple. 3A plus B leads us to 3 Rs. So we start with life. Pardon me. Phone was ringing. Good thing it was turned upside down. So we start with life, which is fraught with ruptures and repairs. We're putting out fires all day long. We have challenges in our interpersonal relationships. This is ongoing. It's inherent, and it's always in service to our growth and resilience. And then the 3 A's, as I present them, is awareness, attending, and alignment. And this is where we take care of our nervous system first. And then we work on the external part of our life. And if we can do that, then we're going to find ourselves more regulated in our nervous system, which is indeed what the AACN and what Goddard et al., among others, have said we need to do for our students. We'll do it for ourselves. We can be regulated. We can have better connection, reconnect within and with others, because we're spending more time in ventral vagal, and we can restore our health and wellness homeostasis. And important in my work, we can heal, nurture our healer's heart and restore that, because it's been decimated by all of the nurse traumatization, and many people are leaving because the reason that they got into nursing has disappeared from their sight and their feelings. But most people were conditioned, and the student that I was in the meeting with was no different. She's like, well, I need to, like, I'm stressed, and, my body's aching, and I'm not getting to exercise, and I can't get to the gym, and, my boyfriend's annoying me, and I don't know, my roommate's on my last Friday, and I'm spending too much money. I can't relax. I'm having a hard time sleeping at night. And I don't even know if I should be in nursing school, if this is what's right for me. And I'm betting that you have heard similar things from your students. And so I sat with her. I'm like, well, these are all important questions, and these are all absolutely wellness domains that we need to look at. But before we do that, let's look here. So here's my model. If you turn it into a pyramid, and we shore up all your self-caring practices, great. But part of the reason that they're not working for you is maybe you don't know which ones to use where your nervous system is at the time. And part of it is maybe that if you're trying to put self-care on top of a dysregulated nervous system, it can be very frustrating. So let's start with inner self-care, with nervous system regulation, and then move and see how that affects the outer components of your wellness, and see if we can get you more regulated and feeling more connected internally, and kind of restore you back to a place of thriving instead of surviving nursing school. Because as I explained to her, our regulated nervous system is like the foundation of a house or a structure. It's got all that rebar and concrete, and you can do a lot to a house before it will blow over. And we should be building our self-caring practices on top of that strong foundation. But what was happening to her and what is happening for many is that because we're dysregulated in our nervous system and we're trying all these different self-care things and they aren't really, maybe some of them are effective. Sure. I'm not going to say, let's not throw everything away. But what I'm saying is if you have a student in your office, as I did mine, who is like, it's not working for me, then maybe this is a direction in which to go, because what she was doing, it turned out, wasn't effective and wasn't sustainable. And so her house of cards kept falling down, and she's really level 1 student. You know, she's overwhelmed and she's wondering if she's in the right place. So if we take a look at my model, just put it next to Maslow's, we can see that there's a lot of parallels. So obviously traumatization is happening at the cellular level, right down to the mitochondria, which is a whole nother conversation for another day. But yes, I've been down all those rabbit holes. I'm such a geek at heart. And so we're supporting our physiological processes by regulating our nervous system and staying in that window of tolerance to the best of our ability, which also heightens our sense of safety. And guess what? If we feel safe in our nervous system, then the threat detector calms down, and not every perceived or real threat or stressor is a 911 emergency. So we're really supporting nervous system regulation and our perceived safety. And then because we're doing that, we're spending more time in our ventral vagal part of our nervous system. And that's where we are open and connected and able to make meaningful connections with others, and which corresponds to our belonging and love. So there's a lot of support for that. So also a lot of information. I hope I'm not talking too fast, because I can do that sometimes. So let's slow the pace. And this is another exercise I use with my students, which is virtual aromatherapy. And they're always like, but Lorre, Dr. Lorre, there's no such thing. And then I have to remind them that, you know, we're not talking about a nursing intervention per se. We're not looking at efficacy. Each person has a unique lived experience and a trauma roadmap. They also have a unique innate care plan. And so the process isn't about efficacy, it's about effectiveness in finding what works for that student's nervous system. So our goals are somewhat different, but really it's about signs of safety to signal to the threat detector that we are well, we are in our bodies, there is not a saber-toothed tiger here, we are okay. But we can't think or speak that to the nervous system, because the autonomic nervous system and all of this is happening subcortically. So how do we get in there and learn that language? And one of the techniques, many techniques, are somatic experiences. And then we want to really help people feel safe in their bodies, and how do we keep them regulated once we do feel safe. So now with that in mind, let's take a look at this image, and I'm just going to invite you, if citrus is not a pleasing scent or flavor for you, that's okay. Pull up, close your eyes, pull up in your mind's eye, maybe it's a hot cup of coffee, or as is the case for me right now, a sip of tea. It might be holiday baking scents. It might be the salt air at the beach. Any scent at all. And just looking at those orange blossoms in the back, that's one of my favorites. So let's just take another round, 3 rounds of 4x4 or any breathing, but I really would ask that you focus in your mind's eye on the scent of and the texture, anything sensory that you can connect to. So I'm gonna be the bell myself, since it's not hearing, and we'll do 3 rounds and get comfortable. And here comes your first bell. Ding. Keep just visualizing the scent as we go into the second bell. Ding. Really smell it to the bottom of your toes on this third and final ding. Notice any sensations. I'm noticing that my mouth is watering. I'm noticing that my jaw is not clenched. Just kind of scan your body and just notice any perceptions or sensations you might be experiencing. And then when you're ready, you can just gently open your eyes and we'll move into the next portion. So how do we recognize these signs in our students? I'm going to send out to you. I don't know if I can show it to you. Let me see. I'm going to try and show it to you from Sam. So yes, I can show it to you. Look at me learning how to use technology. There's a one-pager that we'll send out in the email so you can start familiarizing yourself with how to recognize the immediate and delayed responses or reactions to trauma in the emotional, the physical, the cognitive, the behavioral, and the existential domains. So we will send that out to you, more than we can unpack in the short time that we have together. Let me see if I can get myself back in present mode. Well, it wants me to click a button. Imagine that. So let's see if that does the trick. There we are. Okay, so that's where a lot of this is derived from, and we'll make sure that you get that in a follow-up email. And just a reminder that dysregulation shows up in all of our wellness domains, all of them, maybe not all of them at the same time, but we need to just be aware that dysregulation, it shows up where it shows up. And so sometimes it's overspending, sometimes it's interpersonal relationships, sometimes, a lot of times in our students, what I've noticed over the years is that there's either a stress overshoot, so their stress response is magnified commensurate to the context, or it's it's incongruent with the context. That wasn't the word I was looking for, but it's a close enough synonym. So let's take a look at a couple of these student archetypes that I've developed in my work, and look at how these adaptive responses may not be adaptive in their current situation. So again, just a reminder, they're not conscious choices. This is happening below the level of cognition in the subcortical region, where the limbic system is calling the shots, and the limbic system doesn't think or respond to thoughts. So we have fawning, which shows up a lot of times as people pleasing, codependency, lack of identity, or no boundaries among a host of others. And I want you to be thinking as we go through this, what you might be observing in your students, because I'm going to have some participation case studies, easy breezy, low stakes, just so we can brainstorm, like what are we seeing in our students? If they're in a fight response, are they getting angry outbursts? Are they controlling, bullying, maybe some explosive, erratic behaviors? If they're in a flight response, perhaps they're needing to be perfect. They might be overworking. They might be anxious. They might be chronically overthinking. Or if they're in a freeze response, they might not really be engaging because they literally do not have the energy coming from the mitochondria. I mean, it's a physiological thing. They need to just have less stimulus, so they want to be left alone. They might be brain foggy, indecisive, late, lethargic, or shut down. So kind of keep those in mind, and I'll keep the same image going as we move into our first student. And just in the chat, or turn on your microphone if you're comfortable. Let's just take 30 seconds to do a little data collection. And if nobody talks to me, which I'll be hashtag sad panda, but if that happens, then I'll tell you what I see in my students. So I encourage you to participate however you're comfortable. What fawning behaviors are you seeing in your students? Yeah, I promise I'm not going to cry. No pressure. Let me tell you what I'm seeing in my students. When I have students who are fawning, they are trying to literally need to be, oh, there we go. Thank you. Maybe it's just a leg. Thank you, Jocelyn and Morgan. I appreciate you. I'm no longer a sad panda. So yes, they could be codependent, highly codependent, needing to be perfect. Also, it's the student who's going to email you 42 times a day. Maybe I'm exaggerating, maybe not. I've had students who seem to, over emailing. They're walking me to and from class. They want to sit in my office. Well, I'm working remotely now, but when I was on campus, they want to come eat lunch in my office. They just, they don't have any boundaries. They just need to connect and almost kind of glom on. So that's what I'm seeing, in addition to what Jocelyn and Morgan are seeing. So this is like, you don't even have to answer, but let's just think about this and we'll talk about it at the end. So do you think, just be with this, is the student experiencing a stress response and or a nervous system adaptation? Let's do another case study as we explore that. What about the student who's in a flight response? All right, so flight behaviors, needing to be perfect, overworking, anxious, overthinking. How might that be showing up for your students? I have 9 minutes left. Okay, and I'm almost there. Challenges, grades. Yep.
Meltdowns over things that maybe, low stakes things that push a student to have like a big meltdown when you're feeling like that was really not a reaction that maybe needed to happen there.
Right. All of these grade shopping, always wanting the A, unprofessional emails. Yeah, and even the unprofessional emails might fall into the fight category, right? They might be, moving towards the stimulus. And I had a student certainly was doing that, and that would also maybe be the grade shopping. And so I'm going to move through these quickly because Karen kindly prompted me that, and I am getting close. I think I'm going to end on time, except for if you want to hang out with me and talk trauma, because that's my thing. So here's the fight. This is the person who's like blowing up your email 5 times. You've explained the response to the text question 5 different ways, in person, over Zoom, via email, and they just keep hitting, and they're moving towards the stimulus, and it's almost a form of bullying. It can be. I'm not saying your students are bullying, but that this also could be that angry outburst, like they want something so different, they're so dysregulated that they just sort of have this emotional volcano, and so that could be just depends, fight or flight. And so the take-home message here, and here's the student who's in the freeze, right? This is a student who's always late to class. Their work is always late. It's usually, maybe it's not quite always complete. And it may be because their mitochondria are literally shutting them down. It could be that they were out partying all weekend. I don't know. But I'm going to make the assumption that perhaps they need regulation in the nervous system. And then if I find out later that they were out partying all, whatever. So the point is, in all of these check-ins, is that we don't have to know. We don't have to know, is it a stress response or an adaptation, or in most cases, it's probably both. But what we do need to know, according to the AACN, is that if we assume everyone has trauma and we meet them there, we'll never get it wrong. We just won't get it wrong. And we're going to do them a great service. So how do we go about doing that? And I'm going to skip this time check so we can get you out of here on time, because I think I know the answers. And this is how I know, because I hear this all the time. I don't have time to regulate my nervous system. I don't have time for self-care. I don't have time for any of this. There is no time. There's no time. There is no time. And that is real, because we and our students have so many competing demands that we're navigating. So this is the job I had. How do we help our students with that regulation? And so I have, and here's the code to my YouTube channel. There's the link for it. I have this series broken down in little 3 to 9 minute sound bites for your students, directed towards a nurse or a student. And we're in the process, I and my team, of developing these self-caring videos, the regulation. So those are coming. You can subscribe, and down the road, I hope to propose a course that we can put in the new integrative health program when that becomes a thing, or not. But I'm teaching it anyway. This is my side gig, my passion project. So this is what we're doing. So the first thing to do with your students is to have them check in. How much time do you have now? How much, and it's not how much time do you have, how much time do you perceive that you have? And use the button jar. That big pink heart there, that might be a spa day, right? Or a day hiking out in the mountains or rope climbing or whatever, you know, whatever that looks like for you. But most of our students are right here. And this was certainly the student I had with me today, this little itty bitty button here. And so what I was impressing upon her, and she got it, was that it's micro doses. We need micro doses of nervous system self-care throughout the day. And guess what? You're breathing anyway. So here's a super quick one. Take one mindful breath to separate yourself from the stressor. Let's all do that together. One big inhale, exhale through the straw. That was a microdose of self-care. Let's do another one. You're in clinical setting, you're at the college. Every time you go through a door jam, gently tap your elbow or your foot on it, and to ground and center. That was a microdose of self-care. You checked in. Another one I always have with me, and I have it in my hand right now, any artifact from nature. Right now, teal is the color of the decade for me. I'm stuck on this color, so I have a teal stone. And while I'm presenting to you, I'm making sure I'm connecting with nature so I can stay grounded and centered and bring you my best, healthiest, most compassionate and regulated nervous system. Hand over heart, you've seen me do that a lot today. This is a quick one. And even when students are passing themselves in the hall or in clinical settings, my students would put the hand over their heart in a quick nod, just a. And what that does is through relational neurosciences, that sets up the automatic process of co-regulation, being seen, being heard, being cared for. And I can do this as I blink my eye that fast. Bear hug container, and I'm sure you guys all know this one, but you put one hand under each armpit and give the stress a container. For a minute, give your nervous system, which is firing like it's non-insulated. And what that does is it signals to your threat detector that you're safe. And then, of course, anything. And I see the stones with healing. Yes. The healing stones. Oh my God, they're my life. I have like, Karen, you should just come over. So I have developed all grounded in the current evidence base, all sorts of nurse-specific, and there's more. This is just the first three, then there's the balance one that will follow. These exercises, and this is what my team and I are building out now. I've had to hire people to help me with the videos. I just can't get them all done by myself. And so that's in production right now, coming soon. For those of you who are interested in a deeper dive, there's a couple articles I've linked at the end. And I would be so grateful if you would take a moment, and we'll put the link in the email, if you could give me a tiny bit of feedback, what worked for you in this presentation, what didn't, because I'm taking variations out of it on the road this year on the speaking circuit. And this is the hill I'm going to die, put my career on. This is how I'm riding out the last decade of my career, is on this mission. So anything that you can provide me, there's my contact information, the nursing specific education resources. The reference list is more than you want to read, but it's pages and pages long. And there it is. And there's my references. So in the 28 seconds that are left, is there, and I'm happy to stay on beyond. I just want to be ever so respectful of your time. And I'm just so grateful that you were here and spent this time with me talking about these important topics.